First thing I want to say to our guests is, obviously, this is a very hectic day in the United States Senate, something of an understatement. And I want our witnesses to know that our colleagues are all trying to juggle responsibilities, so I don't want our witnesses to feel in any way the fact that senators will be coming and going minimizes the importance of this hearing. And my friend and partner, Senator Crapo, is an example of trying to be several places at once. And so as we begin, I would ask unanimous consent that Senator Crapo's opening statement be entered into the record after my opening statement. This morning, the Finance Committee meets to discuss the use of artificial intelligence in healthcare. The focus is going to be on the technology that's being used in federal health programs such as Medicare and Medicaid. There is no doubt that some of this technology is already making our healthcare system more efficient. But some of these big data systems are riddled with bias that discriminate against patients based on race, gender, sexual orientation, and disability. It is very clear in my judgment, and technology is an area I've tried to specialize in since my arrival in the United States Senate, when only Senator Pat Leahy knew how to use a computer. It is very clear that not enough is being done to protect patients from bias in AI. We work to ensure innovation, for example, in the 1990s, would improve patient care, and we empowered telemedicine, digital signatures, and other efforts. The Congress now has an obligation to ensure the good outcomes from AI set the rules of the road for new innovations in American healthcare. Today, we're going to discuss the role Congress and the committee must play in helping strike a balance between protecting innovation and protecting patients and their privacy with legislative proposals like the Algorithm Accountability Act, which I have introduced with my colleague and friend, Senator Booker, and Congresswoman Yvette Clarke, a very knowledgeable member of Congress on technology issues, and our legislation would tackle these concerns head on. There are a lot of reasons to be optimistic about the potential of AI to improve healthcare. Today, the industry faces a host of challenges, all made worse by the strain of the COVID pandemic on our health system. There's a workforce shortage. Existing providers are facing high rates of burnout, healthcare costs rising faster than wages, and there is an ever-growing gap between the care that's needed and the care that's being delivered. Already, AI tools are being deployed to reduce some of these pressures and ease the strain on the industry and providers. Some doctors use the technology to pre-populate, for example, clinical notes and their emails to reduce workloads, submit bills to insurers. That helps to reduce administrative waste and even help with diagnostics. Primary care providers can use these tools to screen for certain diseases and connect patients with specialists for treatment. That saves patients time and money and leads to better, more timely care. So that brings us to the area that this committee has had a special interest in, and that's Medicare and Medicaid. Here's an opportunity to improve workload for providers, help patients, all of whom are trying to make sense out of this new AI reality. And addressing these challenges with new technology has to mean better patient outcomes, while at the same time protecting privacy. And that goes right to the heart of my philosophy for now several decades with respect to technology. Technology gives us a chance to innovate, and that innovation is not mutually exclusive when it comes to privacy. Smart policies give you both. They give you innovation and privacy. Not so smart policies give you less of both. So as we begin this effort with respect to AI and these developments, let's keep that in mind. So there are clear, glaring loopholes of AI tools being developed with data that perpetuate racial biases. And I've been pleased to be working on this with Senator Booker and Congresswoman Clark, who've really zeroed in for all of us, in both the Senate and the House, on some of these issues, because these biases have been deployed in ways that bypass important doctor expertise, and it leads to inadequate care for patients. So the committee is very lucky today to have Dr. Ziad Obermeyer, who in 2019 discovered racial bias in an AI tool developed by the healthcare company Optum, a subsidiary of United Health, the United Health Group, and used by providers across the country to offer care management services. Dr. Obermeyer found that the tool, on average, required Black patients to present with worse symptoms than white patients in order to qualify for the same level of care. Folks, that is not a close call. It's just not. And we've seen it in so many other areas, just in the last few days, still trying to sort through the concussion, settlements that have been discussed with respect to NFL players. So I'm very pleased that Dr. Obermeyer is here, and we appreciate his expertise. That algorithm was available to thousands of doctors across the country, potentially impacting millions of patients. How does such a flawed system make its way into general use? Well, pretty hard to figure that's out. Nobody's home. Nobody's watching. No guardrails. No guardrails to protect the patients from flawed algorithms and AI systems. To make matters worse, the technology the insurance companies or health systems use can play a role in what care patients receive and what services are approved or denied. The Department of Health and Human Services does not, as of today, really oversee the use of these systems. Big problem, folks. Most of us here would agree that there are many ways this technology can be used to improve health care and patient outcomes. As long as we increasingly rely on technology like AI to make decisions in every part of our day-to-day lives, the Finance Committee, we're going to work on a bipartisan basis. Senator Crapo and I have talked about this a number of times. We're going to work in a bipartisan way to deal with these crucial issues. And I happen to believe that one of those keys is to have guardrails in place to protect patients, particularly in Medicare and Medicaid, and I don't believe the current laws go far enough to deal with that. That's why we came forward with the Algorithm, Accountability Act. It doesn't answer all the questions, but it's all about common sense. We talk to technologists, we talk to authorities, particularly about some of the first steps. And that's what we did with the Algorithm Accountability Act, to lay the groundwork to root out algorithmic bias from these systems. It's applied to healthcare. Our legislation would require healthcare systems to regularly assess whether the AI tools they develop reflect are being used as intended and aren't, in effect, generating more in what amounts to perpetual harmful bias. Close with this. The same protections in my Algorithm Accountability Act have to apply to Medicare and Medicaid. So what we need, if I could sum it up, is transparency in how the tools are developed and used to foster trust, accountability for how they're used in healthcare, make sure we preserve the privacy of patients, and let's use this as an opportunity to give everybody in America the chance to get ahead. I mean, it's really about, equity. That's what I want to have our committee on a bipartisan basis. And you look at what was done in this committee room with the historic tax reform bill. It was just 86 before a lot of our audience was born. It was all about giving Americans, everybody, the opportunity to get ahead. And that's our country at its best. That's what we're all about. And we got to make sure these tools further equity in healthcare and don't perpetuate harmful bias or disadvantage hospital and providers who service low-income patients or communities of color. The Food and Drug Administration and the Office of National Coordinator for Health IT have proposed some new rules. I think they're a step forward. My own take, speaking for myself, my colleagues, as you know, are juggling a lot today. I don't think these rules go far enough. I believe more is needed to protect patients from flawed systems that can and will directly affect the health care they receive. I look forward to working with my colleagues on the committee to identify ways we can protect patients and improve care going forward. I say to our guests, that's what this committee is all about, is working in a bipartisan way. We did it this Congress with PBMs, for example, these middlemen. We've done it with respect to mental health. We've got a lot of issues on our plate, but we try to tackle them in a bipartisan way. And I want to thank our witnesses for testifying at today's hearing, and I look forward to having them. Now, let's see, we're going to have to introduce these wonderful people. Peter Shen is here, Director of Digital and Automation North America at Siemens. He focuses on introducing new and emerging technologies in the healthcare field. He's an academic star, biomedical engineering, mathematical sciences from Johns Hopkins. Mark Sendak is co-lead at the Health AI Partnership. That's a collaboration between academic systems and businesses and federal entities. Population health and science lead at the Duke Institute for Health Innovation. If I go on and on about Dr. Sendak, you'll be here till breakfast, but we're glad he's here. Michelle Mello is here, and Michelle comes from my alma mater. You know, I wanted to play in the NBA. I got a scholarship to Cal at Santa Barbara, and I didn't get to Stanford as an undergraduate until it was clear I wasn't going to make it. So glad you're here, Dr. Mello. She leads empirical health. She's the empirical health law scholar, and her research focuses on understanding the effects of law and regulation. As I say, she's a professor now at both the Stanford Law School and Stanford University School of Medicine. Stanford Law School is no longer right across from ugly anymore. It's changed. Glad you're here. Dr. Obermeyer, I threw some bouquets out already. We're just really pleased he's here, and he's an associate professor in Blue Cross, distinguished professor at UC Berkeley, who's named one of the 100 most influential people in AI by Time Magazine for his work that I discussed already. And Dr., am I pronouncing this right, Baker?
Baker, spelled
Baker.
funny.
Yeah, that's right, an Oregonian, great. Leading scholar on the economic analysis of healthcare policy. She served as a Senate-confirmed member of the President's Council of Economic Advisors. She received her PhD in economics from Baker. We welcome all of you, and we'll put all your prepared remarks a part of the record. Dr. Baker, where in Oregon are you from?
I'm unfortunately not from Oregon.
Oh, I thought I heard you say you were from Oregon.
No, I did a research project based in Oregon and had the opportunity to spend some time there and had a wonderful introduction
We'll come back.
into
I'm
Portland.
I'm glad we've sorted out your connection. It is
Well,
a
I now consider myself invited to return.
You do. All right, we've sorted that out. Let's go. Mr. Shen.
Chairman Wyden, on behalf of Siemens Healthineers and our nearly 17,000 employees in the U.S. and approximately 71,000 employees globally, thank you for the opportunity today to testify on the topic of artificial intelligence in healthcare. My name is Peter Shen, and I'm the North America Head of Digital and Automation for Siemens Healthineers. My career focus is on the introduction of new and emerging technologies in the healthcare market, including artificial intelligence. Siemens Healthineers is a leading medical technology company with more than 120 years of history and experience bringing breakthrough innovations to market that enable healthcare professionals to deliver the best care for patients. Our core portfolio includes imaging, diagnostics, and therapies augmented by digital technologies and AI. We partner with more than 90% of leading healthcare providers to address population growth and chronic disease prevalence, healthcare workforce shortages, and the lack of access to care to underserved areas. We have the distinction of being the only medical technology company capable of end-to-end cancer care, from diagnosis and screening to treatment and survivorship. This is a responsibility we take very seriously as we keep patients at the center of everything we do. Siemens Healthineers has been working on applying artificial intelligence in medical technology for more than 20 years. At our AI Office of Big Data here in the US, we've created and maintained one of the most powerful supercomputing infrastructures dedicated to developing AI. This allows our research scientists to collect, prepare, organize, and secure de-identified data needed to train and deliver accurate AI algorithms. From its inception, we created and maintained a transparent quality assurance process, which involves clinical validation to guarantee the data being used to train the AI algorithms is accurate for diagnosis and treating disease and is based on a balanced cohort of people of different ages, genders, and ethnicities, thus ensuring that we develop reliable, accurate, and unbiased AI algorithms that protect the patient and are reflective of the patient population that they'll be applied towards. Unlike AI for operational work or workflow improvements that help reduce physician burden or improve patient experience, many Siemens Healthineers clinical AI algorithms can be termed as algorithm-based healthcare services. These analytical services delivered by FDA-cleared devices use AI and machine learning to produce quantitative and qualitative clinical outputs for physicians to use in the diagnosis or treatment of disease that were previously not possible to visualize or calculate without the assistance of AI. The patient journey is at the heart of Siemens Healthineers' AI work, and AI is already helping improve care and outcomes for the patient. Clinical AI or algorithm-based healthcare services can be an important service when used to diagnose neurodegenerative diseases for patients. Changes in brain volume over time can be a powerful predictor of diseases such as Alzheimer's. But neurologists are challenged with needing actionable patient-specific brain volume data to diagnose and treat such patients more accurately. Our clinical AI algorithm services can automatically segment different structures of the brain on an MRI image, measure their volumes, and compare these volumes to a normal brain database. Brain volume deviations from the norm are highlighted in a comparative report for the neurologist to provide additional objective, quantitative information that they can use to make a more accurate and informed diagnostic and treatment, resulting in better patient outcomes. While CMS has recognized the value and the complex nature of algorithm-based healthcare services, the agency's reimbursement decisions have not uniformly and consistently ensured appropriate levels of payment for these services. This inconsistent, unpredictable approach stifles adoption by providers, especially in rural and underserved areas, and therefore restricts patients access to new and innovative diagnostic tests and treatments. We support a solution that ensures a predictable and consistent approach by CMS through a temporary and separate payment for 5 years based on manufacturer-supplied cost data. This approach recognizes the cost to develop and integrate AI into the clinical setting and reimburses for the distinct clinical value algorithm-based healthcare services provide. Guaranteeing a consistent reimbursement process would empower hospitals and providers to invest in AI confidently, ensuring their services are appropriately reimbursed. Without this financial support, these providers will face difficulties in embracing and integrating AI technologies, ultimately potentially denying revolutionary services to patients. Siemens Healthineers believes AI has the greatest potential to improve access to care, assist physicians in the diagnosis of disease, and enable more personalized treatments for the patient. As a market leader in researching and training AI and medical technologies, we are excited about what the future holds. It is critical that we all work together to ensure we create trust with consumers and build ethical, transparent, and accessible AI in healthcare to ultimately improve patient outcomes. Again, thank you for the opportunity to testify before you today, and I look forward to your questions.
Thanks for getting us off to a good start. Dr. Sendek.
Chairman Wyden, Ranking Member Crapo, and members of the committee, my name is Mark Sendak, and I appreciate the opportunity to serve on the panel today. I must note that any views expressed in my testimony are my own and may not reflect those of my employer or the multi-institutional partnership I help lead. I serve as the Population Health and Data Science Lead at the Duke Institute for Health Innovation, DHI for short, and I'm the co-lead for Health AI Partnership. I have been developing and implementing AI technologies in clinical care for over a decade. Since DHI's founding in 2013, our team has developed and implemented over 20 AI technologies in clinical care. We were the first in the US to implement a deep learning model in routine care. We were the first to implement model facts labels for AI tools. And we have incubated 4 companies to commercialize AI products built at Duke. Our team has demonstrated the benefits of AI in healthcare. Duke dramatically improved the quality of sepsis care using our Sepsis Watch system. Duke proactively manages chronic diseases in Medicare patients by using AI to identify patients at risk of complications. But my comments today will not focus on the amazing work I've been a part of at Duke. Today, I'm speaking with you primarily as the co-lead of Health AI Partnership. In 2018, a mentor of mine asked me, how do we get AI out of the ivory tower? At that time, my experience with AI at Duke was unimaginable to people outside of a few exceptional islands of excellence, and there was minimal infrastructure being built to get AI outside into low resource settings. In 2021, I helped launch Health AI Partnership to advance the safe, effective, and equitable use of AI in all healthcare organizations. We exist to get AI out of the ivory tower. The Senate Finance Committee can take concrete action to advance accountability, equity, privacy, and transparency in the use of AI in healthcare. The Medicare program ensures high-quality care for beneficiaries through conditions of participation and other mechanisms. There is a unique opportunity for this committee to strengthen Medicare controls on the use of AI and to facilitate investments in technical assistance, technical infrastructure, and training. First, we can talk about guardrails. Through Health AI Partnership, we work with 20 organizations across the U.S. to surface and disseminate AI best practices. We interview leaders and run case-based workshops to develop practical resources for healthcare leaders asking basic questions. How do I evaluate different externally built AI products? How do I navigate the new FDA clinical decision support guidance? How do I assess the potential future impact of this AI product on health inequities? How do I align organizational processes with the White House blueprint for an AI Bill of Rights? Health AI Partnership resources and programs provide guardrails for high-resource organizations that are rapidly accelerating their use of AI. Adoption of these guardrails by hospitals could be required by Medicare program participation, but guardrails only serve the few organizations that are already on the AI adoption highway. We must also address the more critical need for roads, on-ramps, and bridges, the core infrastructure investments needed to ensure that all people in the U.S. benefit from AI in healthcare. Most healthcare organizations in the U.S. need an on-ramp to the AI adoption highway. They are struggling with clinician burnout. They face razor-thin or negative margins. They are entirely dependent on external EHR vendors for technology expertise and assistance. Simply put, they do not have the resources, personnel, or technical infrastructure to embrace guardrails for the AI adoption highway. Core infrastructure investments are needed for technical assistance, technology infrastructure, and training. 15 years ago, Congress funded the procurement of EHRs along with 62 regional extension centers to support EHR implementation in low-resource settings. While EHRs are far from perfect, federal programs did successfully enable broad adoption of the technology. Healthcare organizations urgently need technology infrastructure that is distinct from EHRs, that enables the efficient evaluation, clinical integration, and monitoring of AI tools. And lastly, training programs are needed to rapidly equip healthcare leaders with the foundational knowledge required to locally govern AI. Local AI governance needs to be a core competency for healthcare organizations. Thank you again for the opportunity, and I look forward to answering your questions.
Dr. Sendak and Dr. Mello, I'm sure you heard your colleague, your seatmate, talk about getting everything out of the ivory tower and no pressure. But I'm sympathetic. I was a guide at Hoover when I was on campus, and I always got lost trying to remember exactly how many books there were because we weren't keeping up. So no pressure, but get us out of the ivory tower, please.
Thank you, Mr. Chairman. So you were literally in an ivory tower.
I was.
Yeah.
I was.
Well, I'm so pleased to have the opportunity to speak with you, and I'm sorry that I'm coming to you today with a voice that's more suitable for jazz singing than testifying. I am part of a group of ethicists and data scientists and physicians at Stanford that evaluates AI deployments that are proposed for use in Stanford healthcare facilities, which care for over 1 million patients per year. And I'd like to share with you the 3 most important things that we've learned in doing this work. First, while hospitals increasingly recognize the need to vet AI tools before use, most healthcare organizations don't have robust review processes yet. They need help, and there are many things that Congress can do to help. Second, to be effective, governance can't focus only on the algorithm. It also has to encompass how the algorithm is incorporated into clinical workflows. And by workflows, I mean how physicians and nurses and other staff interact with each other, with the AI tool, with patients, and with other systems. Conversations about regulating AI mostly focus on the algorithms, but equally important are asking questions about how medical professionals will interact with them. For example, we've looked at the onus that's on medical professionals to evaluate whether model output is accurate given the information they have at hand and the time they have available. Large language models like ChatGPT are used to summarize clinic visits, doctor's notes, and even draft replies to patients' emails. Developers assume the doctors will carefully edit those drafts before they're submitted. But will they? To address such issues, oversight must go beyond the algorithm to reach how adopting organizations will use it. To take a simple analogy, if we want to prevent motor vehicle accidents, it's not enough to just set design standards for cars. Road safety features, driver's licensing requirements, and rules of the road also help keep people safe. Third, because the success of AI tools depends on organizations' ability to support them during use, the federal government should establish standards for organizational readiness and responsibility to use healthcare AI tools, as well as for the tools themselves. But it would be a mistake to enshrine in legislation detailed standards for such a fast-moving field. We must have the humility to acknowledge we don't know what the right standards will be 2 years from now. Regulation needs to be adaptable, or else it will risk irrelevance, or worse, chilling innovation without producing countervailing benefits. The wisest course is for the federal government to foster a consensus-building process that brings experts together to create standards and processes for evaluating proposed uses of healthcare AI. It can also require that entities regulated by federal agencies adhere to those standards and processes. For example, the Medicare certification process could be used to require that hospitals have a plan for vetting AI tools before deployment and monitoring them afterwards. The initiative currently underway to create a network of AI assurance labs is right on track. These centers can develop consensus-based standards and perform some evaluations of AI tools for organizations that lack the resources to do it themselves. Adequate funding is critical to their success. Some aspects of AI review have to happen within individual healthcare organizations, though. They can best identify problems that arise from integration into workflow. Regulatory requirements can ensure that organizations invest in making that happen, just as the federal regulations known as the Common Rule did for ethical review of human subjects research. We've developed such a review process at Stanford. Data scientists evaluate proposed AI tools for bias and clinical utility, and ethicists interview patients and clinicians and developers to learn what they're worried about. Finally, don't forget about health insurers. Patient harm can result when insurers use algorithms to make medical necessity determinations, as recent investigation of Medicare Advantage plans has shown. In theory, human reviewers are making the final calls. In reality, they may have little discretion to overrule the algorithms. CMS's final rule addresses this by allowing algorithmic use by Medicare Advantage plans, but requiring them to account for individual circumstances and have a medical professional review each determination. But even as clarified this week, the final rule leaves open important questions about what it means to merely use algorithms as opposed to letting them drive coverage decisions, or to account for individual circumstances, or to have meaningful human review. So in summary, to support healthcare organizations and insurers, Congress should require that healthcare organizations have processes for determining whether planned uses of AI tools meet certain standards, fund a network of AI assurance labs to develop standards and provide expertise and infrastructure for evaluation, require AI developers to disclose necessary information for evaluations, work with CMS on future guidance for health plans, and ensure that federal agencies have clear authority to require regulated entities to implement these standards. Clarity and specificity are very important here and will be insisted upon by the courts. Thank you, and I welcome your questions.
Thanks very much, and we'll have questions in a moment, and I'm interested also in getting some of your work connected to what's going on in my state at Oregon Health Sciences University. So thank you very much. Dr. Obermeyer.
Thank you for this opportunity to address the committee. I'm a professor at Berkeley, but my research on AI is inspired by my clinical practice as an emergency physician. I've worked in academic hospitals in Boston and now in a small hospital on the Navajo Nation, and I've seen firsthand how medical innovations can save lives. But over my 10 years of practice, I've also made a lot of mistakes. Medicine is a hard job, and I wonder, Senator, if you face similar problems in your work. You have to process enormous amounts. You have to process enormous amounts of information. The information is often uncertain and imperfect, and mistakes have enormous consequences. The fact that I've made a lot of mistakes myself is actually what makes me so optimistic about artificial intelligence. And when we talk about AI, it's often very abstract, so I want to give a very concrete example of how it can help patients by telling you about sudden cardiac death. So that is exactly what it sounds like. People just drop dead from fatal arrhythmias, and that kills about 300,000 Americans every year. The scale of that number is just incomprehensible. Each of those 300,000 is a friend, a family member, a loved one who just disappears. And what makes it even more tragic is that we have a cure. Those deaths are preventable. If we knew those people were at high risk before they died, we would implant a defibrillator to shock their hearts back into a normal rhythm. So it's not just that we miss 300,000 opportunities every year to save those lives. When we do place defibrillators, we often place them in the wrong people. About a third of defibrillators end up in people who don't go on to have a fatal arrhythmia. So we waste millions of dollars, we expose patients to health risks, and we get no benefit, all because we don't know who is at high risk and who isn't. This is a problem that AI can help with. The work that I'm doing today that I'm most excited about uses patients' electrocardiograms, the waveform itself, to predict sudden cardiac death. We do a lot better than current methods, which means that one day we can do better in getting defibrillators into the right people. Take some of those wasted defibrillators away from people we put it in who are low risk and don't benefit, and give them to some of the people who are at high risk that doctors currently miss. In healthcare, it's rare that we get a chance to both save lives and reduce costs. Normally, we have to pick one or the other. And that's why I think AI is going to be so transformative for our healthcare system. The use cases go well beyond sudden cardiac death, extending to cancer metastasis prediction, Alzheimer's disease. AI is helping to discover new antibiotics, and it can even help identify social vulnerability. We can train an algorithm to spot subtle signals in x-rays of injuries that can help emergency doctors like me find patients who are the victims of violence when they come through the ER, which is something that we struggle to do today. Despite all of my optimism, I also worry that AI may end up doing more harm than good if we don't act now. In past work, as you mentioned, Senator, my colleagues and I found large-scale racial bias in a family of algorithms that are affecting healthcare decisions for up to 150 million Americans every year. These algorithms should have been a great use case for AI. They were meant to flag patients who are at high risk of future health problems so that we can help them with their health needs today. But unfortunately, a design choice in building those algorithms made them biased. They predicted a patient's healthcare costs instead of their healthcare needs. Now, costs and needs are very different. Underserved patients, which includes Black patients, but also extends to rural patients and any underserved patients, have less money spent on them by our healthcare system today because of barriers to access and because of discrimination. And that means that the AI saw that fact clearly. It predicted the cost accurately, but instead of undoing that inequality, it reinforced it and enshrined it in policy. Senator, you and Senator Booker sent strongly worded letters to major health insurance companies in the wake of that study, and I believe those had a great impact. But unfortunately, some of those biased algorithms that we studied are still in use today, and similar problems surfaced in an investigation of care denial for use of AI in insurance that resulted in harm to vulnerable patients. I think those examples highlight the need for oversight, and I think there are specific things that this committee can do for the programs under its jurisdiction and Congress in general to help. First, towards your goal of transparency, I think specificity is incredibly important. We should know exactly what an algorithm is predicting. If it's predicting cost, the developer shouldn't be able to say that it's predicting risk or needs or something else. Second, accountability. We need to be measuring performance, and especially performance in protected groups under the law, in new independent data sets that the algorithm has never seen, that are diverse enough to reflect the majority of the American population, not just the ivory tower. This is a basic part of good machine learning practice, and we shouldn't take algorithm developers' word that it's performing correctly. Third, I think that government programs should be willing to pay for AI that generates value and should price those services according to the basic principles of health economics. We don't need to settle for the often poor quality products that are put in front of us by developers today. We can shape that market thanks to the purchasing power of those programs. Thank you very much again for this opportunity.
Thank you, Doctor. And I heard you say, and correct me if I didn't hear it right, I heard you say there are algorithms in use today that are promoting bias. Was that correct?
I believe that is true.
So can you give me a ballpark on how many algorithms are being used today that promote bias in healthcare?
When we did our work in 2019, there was a family of algorithms that included the one that we studied, but was not limited to that were being used not just by private companies, but also by government programs and academic research groups that were all predicting cost, but being used to make decisions about health. The estimate at that point was that this was about 150 million patients every year whose decisions about extra help with their health was being affected. And unfortunately, if you look at all of those companies, none of them have publicly disavowed the use of these kinds of algorithms and have clarified that they are no longer using them.
Well, what was their response to your essentially blowing the whistle? And I apologize to all our guests. I just wanted to kind of freeze frame this question because it's so important since it reflects current bias. So these were big operations in healthcare. These were not like mom and pop shops. And you're saying 150 million people are involved then, 2019, showing bias in healthcare. You brought it to their attention, A, and B, they didn't seem to do anything about it, according to you. What was their response? Not interested? Who cares?
On one level, their response was very positive. So in the wake of our study, I actually worked on a pro bono basis with the technical teams at the company whose algorithm we studied. And we rebuilt that algorithm in the same data sets to predict a different outcome in a way that made that algorithm much less biased. But since then, it's not totally clear what has happened and whether the current algorithm or the algorithm that we developed or the original version is still being sold and marketed for the original purpose.
So would it be fair to say that as of today, because you found 150 million patients were being subjected to bias, you got one aspect of this corrected, but from the seat of your pants, and this is not, I just want to make sure my colleagues get a sense of the proportions here. Your assessment would be probably 100 million patients, even if you take it down some for that one example. 100 million patients today are being discriminated against in terms of bias and algorithms. Would that be fair?
I believe that those cost-predicting algorithms are still being used, and I've seen no evidence that they have been taken out of use or are no longer being marketed for the same purpose that they were originally being used for.
And Dr. Sendak wants to say something, and then we're going to let Dr. Baker get back in the game here. Doctor, so, and I apologize to all of you. I just thought that that was so important to get a bead on the number of people being subjected to algorithm bias. I say to my two colleagues, A, thank you very much, both of you, for coming. And I know there's been a lot going on this morning. We just heard from one of the leaders in the field that it was his judgment that 100 million patients are still being victims as of now to algorithmic bias. Dr. Sendak, and then we'll move on to Dr. Baker and let my colleagues get into this discussion.
So I just want to put a pin in a point where my colleague Dr. Obermeyer led some of the initial work showing racial bias in algorithms. So over the last 6 months, we've been interacting with a disability rights group. Obviously, disability status is a protected class legally that's named in the Office of Civil Rights final rule or proposed rule. And our work with them, there's almost no empirical studies looking at disability bias in algorithms that are currently used. Good. So, I mean, when you ask about bias, I know that we often think about racial bias, but the empirical evidence to look at other vulnerable groups is significantly lacking.
Okay, Dr. Baker.
Thank you, Senator Wyden. I'm honored to be here and have the chance to talk with you all about this very important topic. I'm provost of the University of Chicago and engaged with a number of different healthcare organizations, but of course I'm speaking only for myself. And I wanted to elevate two themes that we've heard about from our colleagues and that I know are of vital importance to ensuring that all Americans have the opportunity to benefit from AI algorithms. The first is that these algorithms can increase the quality of patient care by targeting resources to the patients who need them most. You heard about the case of sudden cardiac death. There are many other examples across the healthcare continuum of places where we overuse care in patients where it is not to their benefit and increases costs and decreases accessibility. And we underuse the same type of care for other patients who go without these vital services that would improve their health. AI algorithms can help us predict who is most likely to benefit from care. There is enormous risk of bias, as you've heard about, but there's also risk of bias inadvertently from physicians themselves. And I would be concerned that every patient who sees any healthcare provider is being treated in a way that is consistent with that provider's experience with individual patients, with things that have happened recently in that provider's patient panel. Adding guidance from AI algorithms can help undo the bias that any individual is going to experience, and putting the two together can improve the quality of care and make healthcare more affordable and make innovative care more affordable, because even very expensive healthcare is well worth it when it improves patients' quality and length of lives, but becomes unaffordable when it's deployed in patients for whom there's really minimal benefit, and it raises the cost of insurance and makes healthcare less affordable for individuals, as well as for federal programs like Medicare and federal and state programs like Medicaid. Now, if we're going to pay for this kind of care to make sure that the best combination of human and data is available, those algorithms need to be tested rigorously with a broad panel of patients in appropriate settings. As my colleague noted, the application of these in different settings may have very different results. What looked like it worked well in a small, homogeneous patient panel may have very different effects for different patients. The way in which algorithms are implemented is going to affect how usable they are for clinicians and therefore how beneficial they are to patients. So we have a strong interest in rigorously testing these algorithms the same way we would for any other kind of medical innovation. Beyond individual patient quality and the value of care, though, I think there's even greater opportunity to reform the way we deliver healthcare system-wide. Right now, there is an under-incentive to invest in care that would improve patients' well-being over decades. And this is particularly problematic for Medicare. Individual insurers or the employers who purchase plans for privately insured employees may not see the return to investing in care that's going to avert a heart attack 20 or 30 years later when patients are on Medicare. There is an incentive to invest in care that patients can appreciate the value of in the near term, but often the long-term benefits of the care may be hard to discern, especially when patients are healthy before they are sick and need the quality of care that the insurance is meant to provide. So there is a strong public policy role to promote investment in the kind of care that will improve health in the long run, and AI offers us a tool to better capture that and therefore better reward it and incentivize it. Just as risk adjustment now provides a mechanism to deter insurers from selectively enrolling only healthy people, having that kind of population-level, long-run risk adjustment can help provide the resources needed to invest in people's long-term health, which is, of course, first and foremost to their benefit, but also to the benefit of Medicare, from whom those patients will eventually be receiving care care. There's also a huge return to public investment in making sure that the data architecture is available to draw in data across silos. The biggest return to these AI algorithms is when you can bring together data from multiple insurers across healthcare and non-healthcare settings to really figure out the care that patients need. That return is not realized by any individual data gathering insurer or employer or even healthcare researcher. There's a role for federal policy in saying there's an enormous opportunity to do better for patients and provide higher value care if we can bring all this information together. But that also then exposes the risk of patient privacy, confidentiality, the risk of discrimination. And so those massive data sets need to be guarded by much more specific and transparent federal regulation to make sure that the data is used to the benefit of all patients, and that is not necessarily the world that we're in now. So thank you very much for the opportunity to speak with you, and I look forward to answering any questions that I can.
Colleagues, thank you all for coming. It's obviously a busy day, and I want to say to our guests, normally the chair asks the questions first, but in deference to my colleagues, because I've been at it basically for an hour or so, I'm going to let all of the senators ask their questions first. And next in order of appearance will be Senator Menendez.
Thank you, Mr. Chairman. Dr. Obermeyer, there's a growing concern that algorithms may reduce racial and gender disparities via the people building them or through the data used to train them. For example, health systems often rely on commercial prediction algorithms to identify and help patients with complex health needs. A study conducted by you and your team found evidence of racial bias in a widely used algorithm. Because this algorithm used ineffective proxies and falsely concluded that black patients were healthier than equally sick white patients, black patients were significantly less likely to be identified for extra care. As Congress considers appropriate payment and coverage policy for AI, we need to ensure that AI is not building upon biases in health research and compounding health equity issues. What steps can policymakers take to ensure that AI can be used to improve health outcomes for underserved and underrepresented populations rather than build on the current health disparities?
Thank you for asking, Senator. I think the two principles that I would say are important that I believe Congress should enforce for algorithms that are being used on patients is, number one, transparency in the form of specificity. We should know exactly what algorithms are predicting. So if an algorithm is predicting cost, it should say that very clearly. And I think that will be part of educating the market of health systems and others who use those algorithms, that if this is just predicting how much someone is going to cost, I probably shouldn't use that to figure out how much healthcare somebody needs, because there are some people who are low cost who face barriers to access and discrimination that has reduced that cost, who actually need more care than their cost would indicate. So transparency in the form of clearly labeling what an algorithm outputs is important. The second is that we need more accountability in the form of evaluating those algorithms in new data sets and by third parties, so that we don't have to take an algorithm developer's word that the algorithm is working well and equitably across groups.
Thank you. Let me just stay with you for a moment. Lack of diversity in clinical trials, something I've been working on for quite some time here, creates gaps in our understanding of disease prevention and treatment across populations. Legislation like my Bipartisan Diverse Trials Act seeks to improve access to and diversity in clinical drug and treatment trials, but more needs to be done. Now, recently, some stakeholders have been using AI to increase diversity in clinical trials by pinpointing community centers where patients with certain cancers might seek treatment. That information helped lift the Black enrollment rate in 5 ongoing studies from roughly 4.8% to about 10%. How can we support stakeholders looking to invest in AI to improve diversity and ensure medicines are representative of a broader population?
Thank you, Senator, for pointing out that AI can actually have huge returns in increasing diversity and equity in the science underlying medicine. I think finding the kinds of patients who don't typically get enrolled in trials today is a very important part of that. And I think, as Professor Baker mentioned, linking data sets together to find those patients, to use AI to identify patients that doctors are currently missing for trial enrollment has great promise for improving the diversity of the science on which clinical medicine is based.
Well, thank you for that. We look forward to working with you and some of your colleagues. Mr. Shen, according to a recent study, there are fewer than 20 AI medical services for which CMS reimburses today. The payment for those services, which include AI systems for cardiology, ophthalmology, and radiology, is inconsistent and varies widely. In 2023, most AI medical services had fewer than 1,000 claims billed nationally. In short, the AI medical services that we have online today are just beginning to be widely assessed by patients. What would more consistent Medicare payments make these services more accessible for patients? And are there any other holes in the way CMS is currently reimbursing for algorithm-based healthcare services?
Yeah, thank you for the question, Senator. So while CMS has recognized the value and the complex nature of FDA-cleared AI solutions, the agency's reimbursement decisions have not been uniform or consistent in terms of ensuring appropriate levels of payment for those products. We support a solution that ensures a predictable and consistent approach by CMS, an approach that recognizes the cost of AI used in the clinical patient care and reimburses with a temporary and separate payment for the distinct service clinical AI tools like algorithm-based healthcare services provides, which otherwise would be unavailable based on the qualitative or quantitative AI analysis that those solutions provide. More specifically, we advocate for CMS to implement a consistent and reliable payment policy for technologies and services that are first FDA cleared, second, a covered benefit under Medicare, and third, that the service must provide a clinical output that supports the physician's decision-making. Furthermore, we encourage Congress to encourage CMS to formalize its existing software as a service policy, which would allow for separate and distinct payment for algorithm-based healthcare services with at least 5 years of consistent payment while given a new technology payment assignment. We believe all of this will allow for better adoption of algorithm-based healthcare services to help CMS collect more data to evaluate the overall value of AI to patients. And we also believe that more data will demonstrate AI's ability to increase access to care and improve patient outcomes.
I thank my colleague. Senator Cortez Masto.
Thank you. I want to thank the chairman and ranking member and the panelists. This is a very timely and important discussion. If you haven't been to CES, the Consumer Electronics Show in Nevada, I would welcome you there. Cutting-edge technology in this space that we are talking about right now in the use of AI, impact it has to our patients, but also the healthcare industry and access. But this is a concern for me, is how do we overlay necessary regulation when it comes to AI, necessary regulation and guardrails for data privacy, because I think that's all part of it when we're having this discussion. But one of the things that also comes up, and Dr. Miller, I'm gonna ask you if you would address this, and any of the other panelists are welcome. I have been reviewing recent investigative news coverage of the use of AI and algorithms in limiting access to skilled nursing services. We've heard this happening in other post-acute settings as well, like home health and rehab care. I share concerns expressed here today about Medicare Advantage plans' use of AI tools in prior authorization decisions. So, Dr. Miller, I appreciate you highlighting these issues with AI and health insurers in your testimony. As you note, CMS recently finalized a rule requiring Medicare Advantage plans to have a medical professional review an AI-assisted decision. So my question to you, and there's two of them, and one is, in your view, is human review an adequate guardrail to ensuring plans are individualized coverage decisions? And does the CMS rule provide enough oversight of the use of AI tools in coverage decisions? Those two questions. Thank you.
Thank you for that important question. I think there are a few alternatives to human review, so that's where we ought to focus. The question that interests me is, what does meaningful human review look like?
Right.
As you may have heard, there was another insurer that used a non-AI-based algorithm to deny care. That did have human review, but the human review on average took 1.2 seconds. And the CMS final rule currently doesn't include the level of specificity that would help plans understand what meaningful human review looks like. In order to enforce incentives to make it meaningful, the second point I'd make is that audits by CMS need to look very closely, as I believe they intend to, at denials where algorithms were involved, to require transparency about when algorithms were involved, and to really look at the patterns of denials and reversals.
Okay. And this goes to, I think, my colleague, Senator Menendez, and I agree with this, as we're looking at AI tools and we're trying to address what we see maybe discriminatory impacts of the data, our use of AI is only as successful as the data that we're relying on. And if the data already has a bias for discrimination or the like, that's a concern. And for us, and this is why this is an important discussion, what role does Congress have to help regulate that, prevent that from happening? I'm going to open this up to the panelists, but to please weigh in. But let me just, I only have 2 minutes left here. Mr. Shen, let me talk to you about this issue as well. And Siemens, thank you very much, is in Nevada. I've been there. I so appreciate the work that Siemens does. A recent survey of health system executives found that while many believe generative AI has the potential to reshape the industry, there's only 6% have established a generative AI strategy. And it's surprising to me that we're talking about all of this, but the uptake is so low in the health sector. Maybe that's not a bad thing, as we're talking about the challenges we're facing right now, but there's also potential positive for AI to do really good work in this space. So I guess my question to you is, can talk a little bit about Siemens' work to collaborate with physicians in developing these AI algorithms, and how has this partnership also impacted that adoption? And then finally, as we're having this discussion, protecting that data and the algorithms are only as good as they are clean and take out that internal bias. How are you addressing that?
Yeah, thank you for the question, Senator. Certainly, I think working with our clinical partners is very critical, not just in the development of our AI algorithms, but also in the adoption of those AI algorithms as well. So from our perspective, we work closely with those clinicians to really identify what is the need that they have, what is the challenge that they have from a clinical standpoint that we should try to create that AI algorithm to help them address. And more importantly then is, what is the patient population that they're representing, so that the data that we use to train that AI algorithm is reflective of that patient population. And then once we actually apply that AI algorithm into clinical practice, it's important that we facilitate the adoption. So what does that mean? That also means educating the clinician in terms of what is the intent of that AI algorithm, what was the purpose, as some of my colleagues have talked about here on that AI algorithm, and then also to provide transparency as to why is that AI algorithm making the clinical decision or recommendation that it's making. So giving that education to the clinician as to why that's happening. And finally, I think the other important aspect is that we work very closely with our clinical partners to gather feedback from them, to really understand how do we improve and continue to innovate that AI algorithm going forward. These are all critical steps that we believe that we need to have a key partnership with the clinician. Yep, thank you.
We've got a lot of our colleagues. I thank my colleagues. Next is Senator Johnson.
Hey, Mr. Chairman. I've heard two witnesses mention the need for transparency, which I totally agree with. But I want to just tell a little anecdote about the lack of transparency in government. CDC, FDA has what they call FAERS and VAERS systems. Prior to emergency use authorization on the COVID vaccine, the FDA, CDC was touting the vaccine adverse event reporting systems. They're going to be watching this. They're going to survey it for safety signals. You lose a couple days away from work, they're going to have a CDC representative calling you and following up on you. That was total BS. After the vaccine was rolled out and they didn't like what VAERS was reporting, they started denigrating the VAERS system. They also created a standard operating procedure which talked about how they're going to analyze that data. First talking about proportional reporting ratios and then empirical Bayesian analysis. First, they denied actually conducting those analyses, then later found out somebody said they actually had done it. So they agreed that, yeah, they'd actually done it. So I've been for over a year trying to get the information from CDC and FDA in terms of their empirical Bayesian analysis of the VAERS data. Now, again, these are agencies that we fund and we pay for, taxpayers. These are government employees that we pay their salaries for. This is a standing operating procedure that they are going to do analysis on the VAERS system. They won't turn it over to me. So I just mentioned that in terms of anybody thinking, well, what we need to do is we need to create AI and government regulations so that we ensure transparency. Nothing could be further from the truth. I'm old enough to remember before we started calling this AI, in medicine we talked about expert systems. I remember a PBS series one time, or a report, and I was really surprised the doctors they were questioning about expert systems, they were really opposed to them. It didn't make sense to me. I thought, why not? I remember Dr. Dean Adele always talking about when you hear hoof prints, think horses, not zebras. Well, every now and again it is zebras. And an expert system, that kind of data could potentially give you that information, drug interactions, that type of thing. I think during COVID, again, I've always thought, I've always been supportive of things like expert systems, AI systems having access to anonymized data. I think that's the real key. How do you anonymize this data so that researchers, a bunch of them can? I think the danger of AI is central control. I think the solution, nobody knows exactly where this is going to go, is as much AI out there, as many systems as possible kind of watching each other, okay, trying to, same thing goes with medical protocols. I mean, it makes an awful lot of sense to have basic medical protocols, but you also have to let doctors be doctors. You have to let them utilize the tool of an expert system or an AI, but then use their training, their medical system, and be able to practice medicine as opposed to have it dictate. I think one of the big problems in medicine today is we don't have very many independent doctors now. They're all part of a system, and they all have to follow exactly what the system tells them to do, and of course that system does exactly what the federal health agencies tell them to do, and the federal health agencies aren't transparent. We got a real problem. We've seen a real corruption of medical science research. It's been a corruption of it, with Big Pharma controlling all these things and, relying everything on random controlled trials that only they can pay for, completely ignoring the use of these other molecules of generic drugs because nobody wants to pay for that. And so again, to me, the real benefit of AI with anonymized information, I think Epic Systems has a system. They're trying to do that. Their clients that agree to provide their data anonymized, they can then do research. I mean, I think that's the kind of model we have to work toward. But I think the main question is, how do we allow that system to flourish, and how do we protect individual doctors, individual researchers, and not have them come under the control and under the thumb of, the medical establishment that has been, I would say, in many respects, corrupted by the Big Pharma. I'll go, whoever wants to take the question, or I'll go to Dr. Becker.
Well, thank you. I think it's vitally important that there be transparency in how algorithms are deployed and in the data that feeds into them. And there's some promising examples, I think, of public-private partnerships there where the cutting edge of aggregating and anonymizing data is, I think at this point, although we'll turn to my colleagues who have expertise in this as well, really sitting in the private sector, in health systems and nonprofits, in entities that have some degree of trust in being able to hold data that is anonymized but merged so that researchers can explore opportunities to find new cures, to find new pathways for patients, that takes the individual's identity away, but uses the full set of information. And that's vitally important to getting those insights. The assurance that you're pointing to, we need assurance that algorithms are actually delivering the outcomes that we care about versus other outcomes that might be easier to find, and that they're representative of patient pools broadly across the country, not drawing just from one type of patient and applying the insights to other types of patients for whom they might do more harm than good.
So just a real final topic. So now we're talking with AI, we're talking about observational data, which the Faucis of the world just denigrate. Because only random controlled trials. So I mean, if we're going to really utilize this, we have to, bolster again the value of observational trials. And we need a lot of people looking at the same data and then have that data transparent. These trials, they're not making, even peer-reviewed, the reviewers don't get access to the data, and that's just wrong.
Bennett's next.
Thank you, Mr. Chairman. I'm grateful to you and the ranking member for holding this hearing, giving us the chance to ask questions, and thank you, the witnesses, for being here today. I wanted to shift us, Dr. Baker, in a slightly different direction than we've covered, as I understand it today, and that's the issue of cost and artificial intelligence. It's hard to believe this, but we spend $4.5 trillion, which is more than 17% of our economy, on healthcare. That's twice as much as any other industrialized country in the world, and I think it's worth asking, it's always worth asking what we're buying for that. Our life expectancy at birth is 3 years lower than other developed countries. We have the highest rate of infant and maternal deaths of any industrialized country in the world. We have among the lowest rates of practicing physicians. This is an incredible statistic, I think. We have among the lowest rates of practicing physicians when standardized for population size, and some of the lowest rates of per capita physician visits in the industrialized world as well. People are told that they should suffer the inconvenience of our system because it's easier for us to see a doctor in the United States, and that actually turns out not to be true. We're having the inefficiency of the system that we have, plus nobody can get in to see a doctor. The same holds for patient hospital stays, and the number of hospital beds were outperformed by other countries around the world, even as we're spending twice as much as they are on healthcare. We're spending enormous sums of money, I think, without seeing the results that the American people deserve. And not only is this bankrupting working families, it's adding billions of dollars to our national debt. Part of this is due to the administrative costs that are spread across our healthcare system. I think that's a big piece of that. And it seems to me that the careful deployment of AI tools that prioritize patients might help. And maybe this is an area where we could actually prioritize patients and not profits in the system. They could remove expensive intermediaries and reduce the paperwork burden and create new efficiencies that could drive down costs. So, Dr. Baker, I'd ask you, how can AI tools address administrative expenses and reduce the costs we see in our healthcare system while improving patient care? If there are other folks on the panel who'd like to get into this conversation on administrative or any other aspects of the healthcare system, please feel free. Thanks, Dr. Baker.
Well, thank you so much for the opportunity to talk about this crucial issue you're raising, that the U.S. healthcare system is not delivering the quality of care and outcomes for patients that we ought to expect, particularly given how much we're paying for it. And I do think AI offers some opportunity to increase patient outcomes, improve patient outcomes, while slowing the growth of healthcare spending by being sure that we're not providing unnecessary care that's potentially harmful to patients and freeing up those resources to do all of the things that we need to for patients' health that we're not delivering consistently now. And I think sometimes there is, in the public discourse, some conflation of high-value care and low-cost care. There's lots of care that is of very high value and very expensive and produces wonderful outcomes, or very high value and low expense and produces outcomes in a really cost-effective way. We want to target resources towards where they produce the most health, that mix of high cost and low cost care that's really appropriate for patients, and AI can help us do that. But even more, I'd like to see us move towards a system of paying for value rather than paying for the inputs into healthcare, and paying systems that produce better patient outcomes more rather than just paying based on how many resources they use. AI can be part of that in that if AI helps a doctor, an insurer, a system deliver better outcomes for patients at lower cost, that should be an advantage there. And we can pay for bundles of care that produce patient outcomes rather than each of the individual inputs.
Is there anybody else who'd like to take my last 30 seconds? Dr.
I'll just add one thing. I through my research and because of family, I spend a lot of time outside of the US, and there is actually nowhere I would rather get medical care than in this country. Now, I'm lucky because I'm a doctor. I'm privileged in lots of ways. I can navigate the system in ways that others can't. And so I think AI has a lot of potential to help everybody, not just people like me, navigate that system. A lot of the administrative decisions, even something as simple as you want to see a doctor, when should you see that person, how early? That looks like an administrative decision, but it's actually also a health decision because it depends on that patient's health needs. So I think AI will be particularly powerful at that interface of these decisions on the back end of healthcare, like population health management, scheduling, et cetera, that are actually both administrative decisions and health decisions. AI can be very powerful there.
Thank you. Well, thank you both, and thank you, the panel. Thank you, Mr.
Thank
Chairman.
you, Senator Bennett. And I would just say the first thing Senator Bennett said, and he is always very informed on these issues, is also worth just a quick comment. He mentioned that we're spending $4.5 trillion a year on healthcare. And ever since I was director of the Gray Panthers, what we would do is divide the number of Americans into the collective spending. Today, far different than when I was coming up, 4.5 trillion divided by 330 million Americans means that what Senator Bennett was just saying, that if we wanted to do it, and this is not how we're approaching health policy, but if we wanted to do it, we could send every family of 4 in America a check for $50,000 and say, good evening, happy to be here. $50,000 for a family of 4. So Senator Bennett, as usual, gets us off on the right track. I thank my colleague. Senator Young, welcome.
Well, thank you, Chairman. I want to thank you and members of the Finance Committee staff. As the Chairman knows, I've been working on artificial intelligence, trying to learn everything I can, working with Senator Schumer and Heinrich and Rounds, and we've held a number of forums on the topic. We've attempted to educate some of our colleagues on what adoption of AI technologies is going to mean for all various facets of life, from national security to labor market impacts to healthcare. And I've learned quite a lot, and the hope has always been that our committees of jurisdiction would sort of grab the bit and run with it, and the Finance Committee's out front here. So thank you to our witnesses for helping us sort through this issue that I would agree with Dr. Bucher. Did I say her name right? Bricker?
Baker.
Baker. I can't even read it. All right, it's much easier. Dr. Baker. You know, I've heard a lot of commentary about the productivity improvements, but also the health and wellness improvements we might realize, and perhaps we'll actually be able to bend the proverbial cost curve down in healthcare. We've tried seemingly everything else in Washington, so maybe the innovators and entrepreneurs and investors can help us get there. So I'll begin with some questions for Mr. Shen, please. Mr. Shen, on issues of workforce, of federal workforce, are there existing gaps in the CMS workforce and expertise that may create choke points to access or to use of AI within the healthcare context?
Yeah, thank you for the question, Senator. Certainly, I think CMS has recognized the value and the complex nature of FDA-cleared AI solutions, but the agency's reimbursement decisions haven't been uniform and consistent to ensure appropriate levels of payment for these products. And I think what we're advocating for here is to ensure some sort of predictability and consistency as an approach from CMS, an approach that recognizes really the cost of AI and how it's benefiting the clinical patient here, and these different clinical AI tools providing both quantitative and qualitative information for that physician to help better the patient. We see an opportunity here to actually create a temporary and separate payment for the distinct service that these clinical AI tools are providing that would otherwise be unavailable for that physician. And specifically, what this committee can do is really to advocate CMS to implement this consistent and reliable payment policy for these FDA-cleared solutions that we have that are affecting clinical AI.
Thank you. And thanks for the actionable recommendation. How can Congress, as it relates to maintaining our competitiveness, how can Congress support continued innovation, responsible use of AI, as well as continuing to assess the future risk? Relatedly, how can we partner with industry to advance these goals?
Yeah, it's a great question, Senator, and thank you for that. So what we see as a real key component for innovation is adoption. And we believe that the adoption of these new and emerging technologies like artificial intelligence will fuel innovation, innovation here in the U.S., innovation by technology companies like ourselves to be able to continue to push the forefront around artificial intelligence. So a key component, again, here is really driving adoption. So enabling providers to be able to embrace this technology without any uncertainty in terms of making the investment in this technology. And by encouraging adoption, that's going to fuel innovation going forward.
Thank you. One elementary sort of piece of information about artificial intelligence, which I learned early on, is to think about the technology. There are three elements. There's compute, that is processing power. There are those who actually train models, so talent, and then there's data. You need a lot of data oftentimes to train these models. You, of course, need appropriate and clean data. Innovation is rapidly changing what's possible, and data sharing can help leverage advancement of these AI tools. How do we balance necessary data sharing with protection of individual patient data and protection of large data sets?
Yeah, another great question, Senator. I think it's very important that the data sets that are being utilized to train these AI algorithms are inclusive and reflective of the patient population that the AI is going to be applied towards. And that's a key component here. So making sure that the data that's being utilized here is focused on the patient population that it's serving.
That's great. Thank you.
My colleague, we've got 4 senators here, and obviously noon is really the deadline, so we can get everybody in, and we will. Let's see. Senator Carper is next, followed by, at this point, Senator Cardin, Senator Blackburn, and Senator Thune, and if other senators come, we'll figure out how to deal with it. Okay, Senator Carper.
Thanks, Mr. Chairman. Good morning, everyone. Thank you for spending your time with us today. Thank you for your work on what's really an increasingly important issue. We've gotten our heads around it. There's a lot of potential here. Also, some real pitfalls if we're not careful. So I want to ask a question. One of them deals with the workforce and the responsible deployment of our workforce. Strengthening the healthcare workforce is an issue of key concern to me, and I know it is to Democrat and Republican colleagues. I consistently hear from providers back in Delaware and other places too, and from health systems that recruiting and retaining healthcare workforce is the #1 issue that our healthcare system faces. In fact, I go home almost every night to Delaware. When we're not in session, I cover my state. I call them customer calls, sometimes to healthcare places, maybe to hospitals and all kinds of places, businesses large and small. And when I ask 3 questions I knew it was customer calls, I said, how are you doing, the business? How are we doing, Congress and state government and so forth? And what can we do to help you? What we hear from almost from everyone, is we need people who come to work. People who are trained, people who are trainable, and can help us do the work that we're doing. But I think with the growing use of AI in healthcare, it's important that this technology be deployed in I'd just say a responsible way that bolsters our workforce, while improving the patient experiences and hopefully outcomes. We have heard AI be referred to as a co-pilot. I'm an old naval flight officer, retired Navy captain, spent a lot of time in airplanes. But we hear AI referred to as a co-pilot. And as we learn of the ways that AI can support our healthcare system, we must ensure that our healthcare providers remain the pilot, not the co-pilot, but the pilot of these incredibly powerful tools. My staff, in fact, my colleagues oftentimes hear me say, find out what works, do more of that. Find out what works, do more of that. And we have seen healthcare leaders successfully deploy AI tools, including healthcare systems in Delaware and other places, in a way that has improved patient outcomes and mitigated provider burden. Dr. Is it Sindak? Sindak. All right. What best practices should we consider on this committee to ensure responsible deployment of provider-led AI?
Thank you for the question. So I'll comment on kind of two extremes that I've seen. So in my testimony, I referred to what I've been able to be a part of at Duke, which is really an exemplar organization investing in the technical capabilities. We have engineers, data scientists, data engineers. We manage projects. We're funded by the health system. That works. That works to develop, to implement, to monitor AI solutions. That is not scalable. That is not an investment that every organization can or should make. So when we started Health AI Partnership back in 2021, we were focused on education. We thought, let's create the best content that we think we can build, put it out there for free, and build relationships with organizations so that they're aware of it and they can adopt it. So our original scope was curriculum development. I think we put out some really great content. We interviewed close to 90 people across healthcare organizations. We identified 8 key decision points along the AI product lifecycle. We put out guides to do 31 discrete tasks. What I quickly realized is education is only relevant if you have people who can take it, people who have time, people who have the foundational knowledge to go through that training and then bring that back to their organizations. And so while the content's great, we've found that we need to go deeper. And that's why one of my main recommendations in my testimony that I'll go back to is technical assistance. So a program that we're going to be launching soon, we're calling the Practice Network. And that's based on other models across the country of kind of hub and spoke support, where you have a center of excellence that provides specialized support to low resource settings. I referenced regional extension centers. So I think if you're asking, find out what works, do more of that. We've seen exemplary examples of this. I will name ECHO, Project ECHO out of New Mexico, that now is used for many different medical conditions. We need to start doing that type of hub and spoke model for AI, and it can't just be content.
All right. I think my time has expired. I have some more questions, but I'll do those for the record.
I thank my colleague.
Thank
Senator Cardin is next.
Thank you, Mr. Chairman. I also want to thank you for holding this hearing, and I thank the leadership for really getting us all engaged in AI. I thought Senator Young's comment about all of us trying to understand AI and then having our committees try to take appropriate actions in order to have the guardrails that are necessary as we deploy AI. That seems to be the general consensus here. We're all struggling as to how to implement that. So, Dr. Obermeyer, let me start with you first, because I was listening to your response to Senator Menendez's points on the equities. And there are many issues involved in AI in medical care, and we hear about designing AI to protect privacy. We hear about designing AI in order to protect security. But I don't hear much about designing AI to protect equity for the underserved communities. So if we are interested in making sure that we really use AI in a fair manner for all populations, how do we incorporate it in the design?
It's a really great question, and I'd say that most of my work has actually tried to answer it. I think one observation is AI is just data. It learns from the data that you give it. And we are always feeding data into AI that reflects the past, the way our medical system looks today and the way it's looked. That's how AI learns. Unfortunately, if AI learns to basically replicate our current system, it's going to replicate all of the inequalities in our current system. And so if an AI predicts who a doctor should see by looking at who doctors have seen in the past, that's going to incorporate all of the biases that reflect the barriers that people face getting into the healthcare system. So when we design AI, and when I think about designing AI in my research and my applied work, I try to think about how we get AI to reflect a patient's health, not a doctor's opinion. So if we can actually design AI to predict objective biomedical outcomes that a patient is going to experience and feed those predictions back to a doctor in a way that helps a doctor say, this person is at low risk and doesn't need a defibrillator to be implanted in their heart. This patient is at high risk and does need a defibrillator to be implanted on the basis of a lot of data that that doctor can't process. That's a lot better than asking an algorithm to predict who gets defibrillators today. Let's just keep doing that. So designing for equity means designing algorithms that look at patients and represent their health conditions in an accurate way and see the individuality of the patient, not just replicating all of the biased and flawed decisions that are currently being made in our healthcare system.
And who sets those guidelines or parameters to ensure that the design systems incorporate that?
I think one of the challenges is that every AI is a snowflake. There are so many different uses, and that's good. We want a lot of innovation. But the problem is it means we can't set one guideline for all of AI. So that's why we need, first, a lot of transparency so that everybody can look at the AI and see, okay, what is it predicting? Is it predicting a good thing or a bad thing? And let me make that judgment. The second thing we need is for that algorithm to be subjected to rigorous evaluation. And so we need that algorithm to be tested in data that it's never seen before. We need to see how it's performing, not just overall, but in Black versus white patients, urban versus rural, all of these axes of inequality that we currently have in our health system to make sure that the algorithm is not just performing well overall, but it's performing well for everyone.
Dr. Sendek, if I could follow up on a similar concern on equity, and that is we have a digital divide. We have challenges with accessibility for underserved communities generally with healthcare, but also our safety net providers don't necessarily have the same capacity. So how do we build into the system that AI will be really accessible, particularly in underserved communities?
And I want to just build off Dr. Obermeyer's comments. I want to emphasize that even when we went out and in our interviews, we asked 10 organizations, how do you assess for equity in algorithms? We got different responses. So we've tried to start to do that consensus building, but it will take investment to build those capabilities. And then, so to your point, low resource settings, and I mentioned this in my testimony, today they are not on the AI adoption highway. Guardrails do not help them because they are struggling to operate efficiently at baseline. So that's where I want to keep pointing to prior federal programs where we made infrastructure investments in procurement of new digital platforms to enable care to be delivered with EHRs. We invested in technical assistance programs. So that's how we're going to reach those communities and just going back to getting it out of the ivory tower in those settings.
Thank you. Thank you, Mr. Chairman.
Thank my colleague next to Senator Blackburn.
Thank you, Mr. Chairman. Thank you to each of you for being here. I had a great roundtable last Friday with healthcare innovators in Nashville. And of course, we've got great work that is being done in health IT there, a lot of AI that is being done. HCA, one of our hospital corporations, has really deployed so many AI tools to help with clinical decision support, nurse handoff, documentation, things of that nature. One thing that came up was CMS and the reimbursement framework. And Mr. Shin, I do want to come to you on this, and I know it's been brought up before. There are deficiencies, there are discrepancies. You've got a coding that calls for this, and this, and then over here you've got this new technology. So this came up at the round table. So talk to me a little bit. Let's drill down a bit more on these deficiencies and these gaps, and how can CMS move forward and fix that so that patients have the access to the best possible?
Yeah, really appreciate that question, Senator. I think you've identified the issue spot on here. With CMS, we are seeing inconsistencies and an inconsistent message in terms of how do we appropriately reimburse for these AI technologies. From a practical standpoint, what we're advocating here for is kind of a predictable and consistent approach that is really focused on clinical AI solutions. So these are really algorithm-based healthcare services that are providing both quantitative and qualitative clinical information to the physician so that he or she can make
Should CMS be more prescriptive in how this gets handed back to them for reimbursement?
Yeah, I think what's plausible here is that there's pathways that are already in place. There's infrastructure already placed within CMS.
So it's our job here at Finance Committee to tighten this up.
To really push them, in terms of consistency and really advocating now for reimbursement for, again, these FDA-cleared clinical solutions that are already covered under Medicare. Yeah.
All right, then Dr. Mello, same type thing on regulation. When you look at the regulatory frameworks and the balance that needs to be there to establish those standards, talk to me about how this keeps up with that evolving landscape.
So I think what your question raises, Senator, is how do we get this balance between innovation and patient protection right? And I think the critical step that CMS and other agencies and Congress could take at this stage is to convene experts in the field to begin to set consensus-based standards about how algorithms need to perform and about how the people who use them need to plan for their deployment. So CMS could do this, for example, as part of Medicare conditions of participation. I think it would be a terrific way to get the attention of healthcare organizations that are using AI tools but not planning for them in the way that they should and not monitoring them.
Dr. Baker, I think I'm saying that correctly. I got it. Okay. You talked some in your testimony about AI's potential to overhaul healthcare payment systems. And as we look at value-based payment models, we're there with you on that. It doesn't matter if it's blockchain, if it's AI, but achieving that potential. So how do you envision policymakers really harnessing AI effectively to refine these payment systems?
Well, I think there are two mechanisms that might be low-hanging fruit in that way. One is that we don't really pay for improving, avoiding future health risk. Right now, if an insurer does a great job at reducing the likelihood of future heart attacks, there's really very little payment associated with that. So there's a real barrier to investing in that kind of care. AI can generate markers of future health risk that we don't currently have. And when we have a good marker
predictive diagnosis.
Then we can pay for it once we
okay.
have a better marker. So that's one mechanism. Another is in sort of smoothing the way that we deliver care now. We can actually reimburse for quality of care that patients are getting today in a much more nuanced way, drawing on the data that we can now process with AI. All of these data sets have existed before, but it was very hard to boil them down into something you can use.
My time's expired. Thank you.
Thank my colleague. Next to Senator Whitehouse.
Thanks, Chairman. One of the unfortunate things about these hearings is we get a really terrific panel of experts on a really complex subject in 5 minutes. So the questions that I'll ask, unless somebody has an immediate response, I'd like to have each of you take for the record so you have a chance to deliberate a bit and think about it and get back to me. I represent Rhode Island. Rhode Island has several healthcare enterprises that we are very proud of. One is what is perhaps the best all-payer claims database in the country. And with that
array of data and information, there's obviously a role for AI in trying to plow through it and seek out either anomalies or associations that might not be immediately apparent. And I'd be interested in question one is any advice that you would have with regard to maximizing the utility of a robust all-payer claims database. So that would be question one. Question two is, are you working in the development of AI with some of the medical specialty groups, orthopedics, cardiologists, and are they, do you think, a useful place for either benchmarking or approval or somehow accrediting best AI practices? And if they are, do you have any good examples of a medical specialty association that is being particularly forward and helpful at looking for the best uses of AI within the specialty? So that would be question two. The third question has to do with ACOs. Rhode Island has two unusually good accountable care organizations. One is Integra, and the other is Coastal Medical. They are national leaders in terms of quality plus savings, and they've done really, really, really well. And I'd be very interested in your thoughts on ways in which artificial intelligence could be used to support the ACO program. To me, the ACO program is one of the most exciting things happening in medicine right now, just the effect that it has on incentives and the way it opens up a medical practice to see the value in non-traditional interventions that will actually help the payment and save money, but would never have been reimbursable under a traditional pay fee-for-service system. So it's in that area, I think, that there's an enormous opportunity. ACOs can be very big, but they can also be pretty small. And I think the best ones, at least in my experience, have been provider groups that haven't tried to pull together too many different interests and struggle through the conflicting interests, but just to be a good ACO provider group providing primary care. So if you could focus your responses a little bit on that type of ACO, a primary care provider ACO, and what should I be looking for or encouraging or trying to support so that we can continue to advance the ACO model as we try to redesign healthcare. I've got 2 minutes and 30 seconds left, so if anybody wants to jump in and use that 2 minutes and 30 seconds on any one of these, okay, go ahead. But these are questions for all of you, and I'd be really grateful if you'd take a moment when this is over and send a written response to me. Go ahead.
So I'll bucket the last two, and I'll speak now from the perspective of Duke. So much of the initial use cases of AI that we were involved in terms of projects that implemented AI were within the ACO population. And to your point, it was a unique environment where prevention of complications that you could build algorithms to predict actually generated revenue.
Yeah,
and
it's a beautiful thing of an ACO.
Facilitated the investment in the technical infrastructure and clinical expertise required to prevent those complications. So to loop in your second question about specialties, so every year our team at Duke DHI, we run an innovation competition where we ask people, okay, bring us your problems and we'll help you identify solutions that we can implement. So what's very, very common is that specialists come to us. It could be an ophthalmologist with diabetic retinopathy. It could be a vascular surgeon with peripheral artery disease. It's been a nephrologist for chronic kidney disease. They come to us and they say, hey, I see all of these complications from chronic illness. If the primary care doc did X, Y, and Z, we could have prevented this. So everyone always points upstream to that primary care doc. So what we've done across multiple chronic conditions is build algorithms that prevent that complication that the specialist has to take care of. we developed a workflow called population rounding, where that specialist actually reviews high-risk cases that are identified by algorithms, and then they collaborate with primary care docs to send them recommendations that the primary care docs intervene on, generate revenue for the ACO. The ACO pays for that specialist time to do the case reviews, and they pay for the technology. And that's been sustained now for 8+ years for multiple conditions at Duke.
Well, that's really interesting because one of the problems that we face with the ACOs is that they're heavily leveraged. Coastal at one point told me that the primary care doctors at Coastal Medical controlled, I think he said 13% of the care of patients, but the ACO calculation was responsible for 100%, with the rest being pharmaceutical specialists, hospitals, and other things. So the more we can integrate specialist and primary care into that ACO model, so it's a little bit more like a general contractor thing, I'd be really interested in following up, and my time has expired.
I thank my colleague, and I didn't mean to interrupt him. We're trying to deal with our clocks. Let's see. Senator Cassidy is next, and then we will have Senator Warner and Senator Warren.
If y'all have been, if I ask questions and say things that you've already answered, I've just been running and dodging protesters. So the question is, how do we regulate this? And I've had 3 options presented to me, and I'd like your kind of take on it, or maybe 4. One, have AI validate AI. And someone says, you got to be kidding me. AI cannot validate AI because it depends upon making sure that they have the same data sets upon which they are trained and are equally robust. Secondly, let's do what we did with the Sherman Antitrust Act. Just give the courts some sort of kind of barriers, guidelines. Okay, courts, you got to stay within this. We can't imagine what's going to happen in 100 years. Courts figure it out. But then someone said, you got to be kidding me. You got to understand something before you can have a court ruling. And you think some judge is going to understand this? No, it was a lawyer who told me that. So I'm a gastroenterologist, so I'm just going to, take it his kind of minimization of the judge's ability to comprehend. The third is to say, if we're talking about healthcare, to go, for example, to the American College of Cardiology. And they say, we want you to be the third party that will validate that everything out here is going to be okay for a cardiology patient. Now, since a cardiology patient with congestive heart failure can have kidney disease and can have diabetes and can have hypertension and be at risk of stroke, I think you almost end up treating, by the way, be HIV positive. It almost seems like you end up the whole shebang, even though you think you're going to limit it. But actually, that's the one that seems most valid to me because you actually have subject matter expertise kind of penetrating there. Now, I've given you that context. Clearly, I'm meditating on this before I go to bed. Let's start with you, Dr. Baker, and then just work down. And please be tight with your answers.
Thank you. I think it is crucially important that humans be involved in validating the outcomes, but I hope that there's an opportunity for public-private partnership and also for consortia of private entities to have multiple views on the same data set in different contexts and have consensus across them in which algorithms are actually achieving the goals that they say
Practically, that seems that that's going to be incredibly cumbersome. And this seems like a really agile field that's going to race ahead.
But that's why I think having a fixed structure is less likely to be agile than having multiple parties able to weigh in on whether the algorithm.
Now, some of this is proprietary, so would that kind of defeat it if it's proprietary?
I think there needs to be regulation that ensures access to the outcomes and to the crucial inputs of the data so that third parties can see what's happening.
Okay, Dr. Obermeyer.
I think there's a nice analogy to how the FDA regulates drugs. When we regulate drugs, the FDA requires that the manufacturer specify the primary outcome. What is the health thing that this drug is affecting? And it requires them to show that the drug affects that outcome in a rigorous way, usually via a randomized trial. With algorithms, I think we should know what the algorithm is predicting, and then I think we should rigorously evaluate how that algorithm is doing its job in a new data set that it's never seen before, which is a key part of how machine learning gets evaluated everywhere. And I think that
Now, that would presuppose, though, that every time you update it, you got to do retesting.
So I think that there's ways to put in structures for continuous monitoring. So it only requires the algorithm to produce.
I'm running out of time. Dr. Mello.
I think we've learned that there are models that can usefully evaluate some aspects of other models. For example, the developers at Stanford released a model called A+ that evaluates algorithmic bias as an open source tool. That's great. But there are so many other aspects of safe and responsible use of AI that do require human review. I think physicians can be very helpful in spotting issues that will happen when physicians interact with those tools. But generally, I don't think medical professional societies are fully up to the task of vetting some of the issues
Then
that
who
will
would be?
arise. I think you're talking about creating what we might call assurance labs that bring together data scientists
Okay,
with
Dr. Sindak?
ethicists.
Sorry. In silico testing in a third-party validation environment is necessary but not sufficient. And as a practicing physician, different environments are different. Every healthcare organization needs to be able to locally govern AI, and that means
That seems impossible.
they locally govern quality of care, and healthcare services will
I can tell you, the
become-
small little rural hospital ain't going to do it. But Dr. Shin, Mr. Shin, I'm sorry.
Yeah, I think, Senator, it's very important here to really distinguish between FDA-regulated AI and other types of AI, like generative AI. I think FDA-regulated AI, again, goes through a regulatory approval process with the FDA where we have to declare the intent of these AI algorithms and what is the clinical use associated
But clinical
with these.
support,
And the
for example, how do you deal with a heart failure patient?
Exactly. So that framework actually is sufficient to support AI innovation. And we can support kind of this continued flexibility in that approval process to look at how clinical AI can be adopted going forward.
Thank you. I
I
yield.
thank my colleague. We can get both of our remaining senators in before the new
Thank you,
deadline.
Mr. Chairman. Thank you for doing this. I just want to follow up, Senator Cassidy. Bill, I just want to say one of the things I think we got to grapple with as well is intent. Sit on the banking committee where we're seeing AI tools that might have this notion of go make money, but then use illicit or illegal ways to do that. And I think this question around, intent may be to have an AI tool that deals with heart disease, but if you don't have all these other inputs, it could be a challenge. Dr. Sendak, I want to start with you. I'm very interested in your work on developing model disclosures for AI. But I worry, like I'm a tech guy for 20 years before I got into this business, is that there's such a first mover advantage. And if we don't get that disclosure form right, and I know you've talked about, using even maybe the nutrition guide tools. I've got my little, quickly take a photo. I don't know, but so on this kind of model, I think it's an interesting model. You've got it going, at least in your testimony, I think, to clinical end users, but I don't think, did you weigh in on whether actually consumers should be getting the same kind of disclosure? And then how do we make sure that it's actually intelligible, if you do think it, or is there a concern with giving it to the actual patients themselves?
It's great to see that people actually read papers, because when you write them, sometimes it's like just your mom.
Well, in full disclosure, I have staff that has read everything you've all said, but
Thank you.
I got the photo up, Bill.
So I want to touch on a few things. You talked about first mover advantage and the concern with disclosing what is proprietary information. I want to emphasize that, put this in the testimony, we've incubated 4 companies. There are companies that have licensed the algorithms that we've built that they are now commercializing. They are validating them in other settings. And these algorithms all have model facts labels in our publications. So there is a balance between disclosing information about an algorithm and retaining what is needed for commercial rights to be able to commercialize products. And then the second point is, who's this for? And I want to emphasize there too, we built that document that you showed for a specific use case, which is frontline clinicians, so that they know how these systems work. That is not the set of information that an organizational governance body needs to be examining to make a procurement decision. That is not the information that a governance committee needs to look at maybe a few times a year to reconfirm use or look at monitoring. So there's a set of artifacts that need to be developed at different points in the
But
life
again,
cycle.
you talked about the clinical end users. You didn't talk about the notion of Should there be some form of this that
For the
goes to the
public.
patient? And how do we use Medicare as a forcing mechanism to, one, get some level of
Yes.
standardization to a level that even a clinical end user may not understand this, let alone a actual patient?
And the only example I'm aware of a public AI inventory by a healthcare provider is the VA. We are working through Health AI Partnership to build what we're calling the Community Transparency Registry, where we're going to do one use case, and we'll use Duke as an example, where we interview community members, do focus groups, solicit concerns and questions, and develop documentation for the public. And I will say that's a huge gap. Doesn't exist today, and it should be part of
Well,
Medicare
I think we need
program.
to rethink, and I want to get one last question in, and Senator Warren's been very patient. So, Dr. Mello, I just, in your testimony, you talked about automation bias, how we're not going to default to thinking the AI model's always right. Again, I'm interested in how we use Medicare as a tool, and potentially even, I think we do have to raise, I mean, as Senator Cassidy said, some level of liability issues. And I know lots of folks have already talked about bias and hallucination. You want to talk to that a little bit more in terms of how we deal with this automation bias?
Well, I think creating standards, for example, Medicare conditions of participation that require organizations to have given hard evaluation to how the humans interact with the model under the constraints and incentives that they have within that organization is going to be the key to that.
Last, and this, I just asked this, and I'd love to get feedback back so I can don't have to answer it. I'm chair of the Intel Committee, and Senator Wyden's a great member of that committee. We spend a lot of time on cyber. There's a whole new way around AI tools with prompt inquiry and others that don't really fit neatly into the bucket of cyber, but there are ways that we can manipulate these models in a huge way. I would welcome your input on how we do that. Thank you, Mr. Chairman.
I thank my colleague, and I'm also interested in that last question of Senator Warner's. Okay, Senator Warren.
All right, thank you. So over 31 million Americans are enrolled in Medicare Advantage, or MA, the program that allows private for-profit insurers to offer Medicare coverage. Now, under federal law, these private insurers are required to cover all Medicare Part A and Part B services. But in recent years, government watchdogs have found that private insurers are routinely delaying and denying care because doing so boosts their profits. In 2019, the Health and Human Services Inspector General found that nearly 1 in 5 payment denials by insurers in MA violated Medicare coverage rules, meaning seniors were unlawfully denied access to services that they were by law entitled to. Some of the largest insurers that offer MA are now relying on flawed artificial intelligence tools like predictive algorithms to scale up their efforts to deny coverage to seniors. These algorithms sift through millions of medical records to determine the level of patient need that the algorithm thinks they need. So, Professor Mello, you're an expert on AI and health policy. Let's start with an easy question. Does federal law require all insurance companies to follow Medicare coverage guidelines, even if they are using AI algorithms to determine coverage?
Yes.
Yes. So the law is not suspended just because you used AI. I just want to underscore that. Because it is clear that these companies are not playing by the rules. So take United Healthcare, which covers more beneficiaries in MA than any other insurance company. In 2020, United Healthcare bought Navia Health, a company that sells its AI services to insurance companies, in order to help them make these coverage decisions. Last year, an investigation revealed that United Healthcare had pressured employees to strictly follow NaviHealth's algorithm determinations, leading these human beings to systematically deny care at skilled nursing facilities, even when those decisions were against doctors' orders. Dr. Obermeyer, you've conducted extensive research on how algorithms are used in healthcare. Can you talk just a little bit about the dangers that come from solely relying on AI algorithms to make these coverage decisions?
in the case you mentioned, like in all other cases, AI learns from historical data. So it trawls through those millions of records and it sees, for example, that there are some privileged people with great insurance who probably stay in nursing homes for longer than they should. And there are also vulnerable, underinsured people who are often kicked out too early. And rather than undoing that problem, the AI reinforces it and encodes it as policy. And I think that's very contrary to the spirit of medical utilization review. And it's also a huge missed opportunity because I think well-designed AI could do much better. It could look at the patient's x-ray. It could look at the public transportation in their neighborhood. It could look at the layout of their house and integrate all those things into a far better judgment than a doctor is able to make about who needs to be in that nursing home and who doesn't.
So it's a really important point that you make about how it takes the bad information and accelerates, or the information that tells us about bad practices. You know, according to the investigation from the Inspector General, some seniors, these AI denials led to, quote, amputations, fast-spreading cancers, and other devastating diagnoses. I appreciate that CMS has now finalized a rule to increase transparency requirements on insurers' AI systems and require doctors to verify coverage decisions. But I think we need a lot more to protect patients here. So if I could come back to you, Professor Mello, in addition to the rule that the agency has just finalized, what measures do you think that CMS should take to ensure that private insurers are not leveraging AI tools to unlawfully deny care?
Yeah, thank you for the question. I think it's really important to look to see whether they are, given the incentives involved. And I was very heartened to see in the FAQs released this week on that final rule, CMS plans to beef up its audits in 2024 and specifically look at these denials. That seems extremely important. But beyond that, I think additional clarification is needed to the plans about what it means to use algorithms properly or improperly. For example, for electronic health records, it didn't just say make meaningful use of those records, it laid out standards for what meaningful use was.
So I think the point here is we need guardrails. And without significant guardrails in place, these algorithms, as you put it, Dr. Obermeyer, are going to accelerate the problems that we've got and pad private insurers' profits, which gives them even more incentive to use AI in this way. Until CMS can verify that AI algorithms reliably adhere to Medicare coverage standards by law, then my view on this is CMS should prohibit insurance companies from using them in their MA plans for coverage decisions. They've got to prove they work before they put them in place. Thank you. Thank you, Mr. Chairman.
Thank my colleague, and I think Senator Warren's points are very important. And the reality is, not only do we have jurisdiction here, but what is striking, and I've always thought this since my Gray Panther days, is that Medicare is the flagship program in America. And when Medicare does something, everybody in the private sector pick up on it. So these are very important questions, and I appreciate Senator Warren asking. She focused on Medicare. I'm going to use the word that hadn't come up over the last 2.5 hours, and that's Medicaid. And so here's where we are. We know Medicaid is a lifeline for millions of the most vulnerable people in the country, and how Medicaid determines eligibility or the amount of a benefit is of critical importance. Millions of families and children count on the program for affordable health care. Increasingly, the states are using algorithms to determine eligibility and benefit level determinations instead of trained employees. Certainly a prospect for distressing outcomes. For example, Tammy Dobbs, an Arkansas woman living with cerebral palsy, had her home care hours suddenly cut by 40% after an algorithm was used to redetermine her benefit allotment, leaving her state basically, leaving her in a state of confusion and panic. So we've got a lot to do to make sure that we shore up the rules to protect people in these healthcare plans, because they are particularly vulnerable. And in addition to the states, I'd like to address a question to you, Dr. Mello, and you, Dr. Obermeyer, about insurance company discrimination in Medicaid managed care plans. We're staying on the subject of Medicaid as we wrap up, because those are the folks that are most vulnerable, and something strikes me as fundamentally unfair that we've been at it for, close to 2.5 hours and never has come up. So the committee is doing our own investigation into these Medicaid managed care plans, and our investigation includes these issues with respect to insurance company processes that can harm people on Medicaid. So Dr. Mello and Dr. Obermeyer, you got some of the best investigators on the planet sitting right behind me here at the dais. What would you tell them they ought to be looking at in order to protect Medicaid patients through our inquiry, our investigation that will incorporate these AI issues? What would you tell them to be looking for?
Well, first, thank you so much for undertaking that critically important work. I'm even more concerned about those beneficiaries than I am about Medicare beneficiaries, because we know for a variety of reasons.
3 cheers for you.
Yeah, thank you. They have difficulty challenging those decisions. So the number one piece of advice I would give is don't look at grievance, appeal, and overturn rates as a good indicator of humans in the loop correcting errors. Because even if we see, as we have with some other health plans in Medicare Advantage, 90% overturn rates of these initially mistaken algorithmic decisions, this group of enrollees does not appeal and enforce. Again, they just simply don't have the social capital to do that. So second, I think we want to get a handle on what algorithms are being used and for what purpose. And then third, really look under the hood at the kinds of incentives and constraints the frontline reviewers have, the amount of power they actually have to overturn those decisions, by talking with them confidentially, if possible, about, again, what will happen to them if they say no.
The staff was writing very quickly, so you connected. Dr. Obermeyer.
I want to draw attention to one key difference between Medicare and Medicaid that I think really hurts our ability to understand both the promises and the pitfalls of AI for Medicaid, which is that unlike Medicare, there's no one place you can go to look for data. You have to pool all of the data together from individual states. And for researchers, that is actually really, really difficult, and it prevents people from doing the kind of work that I think is really needed, that I've done around auditing these algorithms. All that said, I think Medicaid, like everywhere else, we have the same problems of a lot of people who are currently ineligible, but who are ineligible. And in the people who are covered, there's fraud and abuse. And I think AI has a lot of potential to fix both of those problems. I've seen social workers in the ER struggle to understand who's eligible and who's not. I think that's a huge opportunity for using AI to better structure the eligibility decisions. I also think there's a huge opportunity to use AI to identify exactly those abuses that are happening in these Medicaid managed care plans. All of that requires access to the data and the ability to do that work.
We've been at it a long time. You all have been wonderfully patient. This has been a superb hearing. Not a bad point, or frankly from my colleagues, not a bad question in the House. And we got a lot to do. And I'll just close by way of saying that one of the other aspects of this that the Senate's going to have to get its arms around, this is very different than what we were tackling in the 1990s when we were talking about platforms and things like that. Today we're generating a lot of content, and we need really strong guardrails. Those really strong guardrails are just fundamental. And as we kind of march into this kind of new era, we're going to have good counsel from all of you, and also you're going to get some questions through the record. They're due by 5 p.m. on February 15th, but we want to thank you all and look forward to seeing you sometime soon, Dr. Mello, on the Stanford campus. Lots of friends, and you may have run into one of my classmates, Dr. Linda Shortliff, who taught at the Stanford Medical School, and a lot of other friends. So I appreciate all of you, and with that, we're adjourned.